So if your kids are markedly better after that initial golden hour of therapy, then and they appear to be ready for discharge, our recommendation, not based on randomized trials, but lots of experience, that if they continue to be minimally symptomatic for a good hour after that initial therapy, then at that point it's safe to discharge them home. However, if they still have enough distress that they aren't ready for hospitalization, so they still have a fair amount of indrawing along with their wheezing, or if they have hypoxia, then the appropriate treatment for those kids is to continue to give salbutamol every 30 to 60 minutes as needed, to wait for what we refer to as the corticosteroid effect. And we know that the longer you wait, the more corticosteroid effect that you get, and that a practical cut point is around 4 hours, so that 4 hours after steroids are given, that's a reasonable time to say, well, if they're still working hard enough that they're not totally okay to go home, then it's best to bring them up. However, I just emphasize that if you have the time and the place and you don't have a push on for beds, that if you were to wait 6, 8, 10 hours, that increasing proportion of kids would be able to safely go home directly without admission. That we see increasing benefit from corticosteroids 6 to 8 to 10 to even 12 hours after treatment with the oral corticosteroids. Now, what do we do if the patient comes in with severe symptoms, and even if after that aggressive first hour of treatment they still have severe symptoms? So that's a rare percentage of all kids. So it's probably on the order of 1% or less. But for those kids, it's really important to do two things. So the first thing is to continue to give them nebulized salbutamol in a large volume nebulizer. We also recommend, if you're comfortable with this, treating with IV magnesium. There's good evidence that that additional treatment in that population of patients substantially helps. At the same time, unless you're really used to treating these more severe patients and you don't feel the need to refer these kids to the children's hospitals, then we'd recommend you're being in touch with Rapid to arrange for appropriate transfer to one of the children's emergency department, or in kids with severe symptoms, the intensive care unit. So what should you do if you have one of those rare children with impending respiratory arrest? You'll recognize those children because they will be very lethargic, they will be glassy-eyed, they won't be able to focus on you. They may have minimal respiratory effort because they're at the end of their rope. They're really fatigued and ready to arrest any moment. So if you see those, you're unfortunate enough to see those children, what would we recommend doing? First of all, 100% oxygen via non-rebreather face mask. There now are masks available that we can provide you information on how to order that allow you to give 100% oxygen at the same time you provide nebulization. You would give continuous salbutamol and ipratropium. We recommend that you consider IM epinephrine. While there isn't randomized control evidence of their benefit, there is very good anecdotal evidence from across North America and many people recommending using IM epinephrine. Your first maneuver is not to put in an IV. Important that you do the nebulization, the oxygen first, but then a subsequent IV may be appropriate. And then, of course, contacting rapid south or north is one thing you want to do right away. We recommend that you avoid intubation if at all possible. These kids really can, with ongoing treatment, can usually hang out much longer than you might imagine. And that often is a better scenario for them. They're less likely to develop complications if you don't intubate them than do.